This week on the BackTable podcast.
And again, I just care about kids because they're fun to take care of, but there is a bigger market size actually for the older people that you take care of that have, gunshot wounds or cancer surgeries or what have you. So that we need, as a society, we need to push hard to have better off-the-shelf strategies rather than doing a free flap, which is taking a piece of your leg and putting it in your mouth. It doesn't sound, I mean, if you need it, but it doesn't sound great if you could avoid it or get something off the shelf. So it's really that curiosity and harnessing in on those pain points that you and I see in surgery and saying, why are we doing it? I mean, there has to be some, if I can have an iPhone that's the size of my palm that solves every problem I never knew I had, right? Why don't we have that same sophistication and have different therapies, because we haven't moved the needle on any of that in a long time.
Hello, everyone, and welcome. This is the BackTable ENT podcast. Here we bring you conversations with the best and brightest minds in the field of otolaryngology, with a hope that you can take this information and apply it to your practice. Thank you to our listeners who have been listening to the show for tuning in, and for any of you new listeners, welcome. Market declines, unemployment, the COVID-19 pandemic. Don't let headlines derail your long-term financial strategy. This BackTable episode is brought to you by Yafi Tadessa, Edward Jones financial advisor in Dallas, Texas. He'll work with you to help you understand the impact of short-term events and how to prepare for the long term. Learn how he can help you reach your financial goals. Visit edwardjones.com/Yafi, YAPHET-Tadessa, TADESSE, or backtable.com/401k for more information. Edward Jones, member SIPC. Ash, you know how important it is for understand how our money works and how we can save for retirement. I invite all of our BackTable listeners to sign up for a webinar that Yafi is giving. Just go to backtable.com/401k for more information. My name is Gopi Shah, and I'm a pediatric otolaryngologist here in Dallas at Children's Health.
My name's Ashley Agan, and I am a general ENT. I also practice in an academic setting here at UT Southwestern in Dallas. We've got a great show today. How are you feeling, Gopi?
I'm feeling very good. Very good. It's Sunday, and we have an awesome topic and a super, super, super smart guest who I'm super excited to talk to today. It'll be great.
For sure. Yeah. Any day that I get to do a podcast with you, Gopi, is a good day. We have Dr. Stephen Goudy. He is a professor in the Department of Otolaryngology, Head and Neck Surgery at Emory University in Atlanta, Georgia, where he is the director for pediatric otolaryngology. Dr. Goudy obtained his medical degree from the University of Louisville School of Medicine. He stayed there to complete his residency in otolaryngology and then went to University of Iowa to complete his fellowship training in pediatric otolaryngology. Cleft and craniofacial disorders are his primary clinical and basic research interests. He does translational research working with a team including orthopedics, internal medicine, and biomedical engineering at Emory, and genomics at Georgia Institute of Technology. His research team looks at bone and soft tissue biology to develop regenerative therapies for children. The ultimate goal of his research team is to provide off-the-shelf solutions to reduce morbidity in children undergoing craniofacial surgery. He also obtained a master's in business administration from Emory and is the CEO and founder of a startup company, Dr. Knows Best, which develops novel solutions to alleviate upper respiratory tract infection symptoms in children. He is here today to talk to us about cleft care. Welcome to the show, Steve.
Welcome.
Thank you. Very excited to be here. It's an honor.
For our listeners, can you first tell us a little bit about yourself and your practice?
Yeah, I'd love to. So as you stated, I'm a pediatric otolaryngologist, or, I pick boogers and earwax out of babies for a living. So I love that. I do love cleft and craniofacial care. I guess I'm a nerd and I love science, and, the embryology of facial growth and development is fascinating to me, and taking care of those patients is quite special. Number one, it's a transformative experience for the families to have the surgeries performed. But moreover, I'm able to follow them until they're 18 or 19 years old. And so I really get to know them. So, but there's a lot of general pediatric ENT that I do, and I love it. I mean, it's fun. Kids want to get better. They don't complain as much. So Yeah, it's great.
So the topic of cleft lip and palate is a pretty big topic. Can you first just kind of explain what that is and what it means? Just kind of set the stage for what we're going to talk about today.
So cleft, the meaning of the word cleft is separation. So a cleft of the lip is a separation of the lip. So when your body is forming, your face is growing from the sides to the middle, and the middle part's growing down. And if they don't grow fast enough to touch, or they grow fast enough to touch, but then they don't join, then you get a separation. And so we all start out with a cleft lip. We all start out with a cleft palate. And so for whatever reason, genetic or environmental or some combination therein, about a 1 in 1,000 live births in the U.S. have a cleft or a separation of the lip or the palate. And along with that can be other differences, which would make it a syndrome or a constellation of findings, or it may be cleft lip alone, or cleft lip and palate alone, or cleft palate alone. So each one of those sets the child on a different surgical trajectory, as well as care and care team trajectory. And certainly it's a team sport. So there's, at the very beginning, it's not about any surgery. It's about feeding and breathing and so on. And so there's special bottles that families need to use, working closely with a speech and language pathologist. And then there are teams of folks. And so there's the American Cleft Palate Association, which is an organization that's dedicated to the care of patients that have these differences. And, seeing a team of folks is what's best, because then, the team comes to you versus you going to this appointment on Tuesday, this appointment on Wednesday, and each doctor or care provider is pointing at the other one who's responsible for, doing something. So it really is a kind of patient-centered approach to care.
So when do you first see these patients? Do you feel like now in the last, with prenatal ultrasound, you see these patients, or families, not patients, if you will, but families, before the baby's born? How often does that happen? Or do you then, usually in the NICU, do they call you and then you go see the baby? At what point in time do you start seeing these babies?
It's a great question. I think, as you mentioned, we are identifying these differences earlier and earlier. Certainly, if there's a cleft lip, that is easier to detect than a cleft palate alone. If you've seen an ultrasound, you know that babies are in a quiet, dark environment. And then when you put the ultrasound on them, and they start wriggling around and moving, and it's hard to really identify some of these differences. The face grows and develops very early in life. So around the 10th week, their face is almost fully formed. So if you're getting your 20-week ultrasound, then you will be able to identify some of these differences. And then therefore we can have conversations with the families, and just to help them understand that, that this is not a consequence of them having a Diet Coke on Tuesday or eating Taco Bell on Wednesday, or there's not any attribution or blame, and to help them identify what their child's care path is going to be, and demystify it. Certainly we do also get consulted in the NICU for folks that may have not had good access to prenatal care, or that it wasn't identified prenatally. And at that point, we sit down and have a conversation about what the future looks like for Susie or Johnny or what have you.
And so when patients first present to you, you mentioned that, the first thing you're worried about is just kind of basic, can they feed? Are they breathing okay? Like kind of just getting all of that intact. So then what happens after that, as far as, timing of repair and different things? And how does the type of cleft, or if it's cleft lip and palate, how do the different combinations affect the timing?
Right. And so one of the things I would say for your listeners is that babies are obligate nose breathers. And so, if they do have a cleft in their lip and it's fairly wide, then that gives them actually more space to breathe through. If there is a cleft or separation in the roof of their mouth or a cleft palate, then they can't suck very well. So really, that suck, swallow, breathe rhythm is interrupted, and there's a lot of time spent just getting them to eat, because before we can really consider operation, they need to be healthy and growing and nutritionally taken care of. So So really feeding, there's specialty bottles. There's something called a Haberman bottle, a Pigeon bottle. There's a Dr. Brown specialty bottle. I don't have any disclosures with respect to bottles, so I'm bottle agnostic. There's a lot of different ones. I would say the Dr. Brown specialty bottle is found in Target, so a lot of families use that one. And so assuming that we are on a good trajectory to eat and feed to grow, and that they're gaining weight, that the adage for a cleft lip repair, which is typically the first thing that you do, is 10 weeks, 10 pounds, and 10 grams of hemoglobin. And again, that's an old adage. I don't think that there's necessarily that's scientifically based per se. And that would be, in my mind, the earliest that you would do it. I think there's some folks that are pushing that envelope and trying to do it earlier and earlier just because they feel that there's still some of the maternal progesterone and other things in the system that allow the body to heal in a less scarring manner. There's also some orthodontic stuff or procedures that can be used called nasal alveolar molding, where it actually brings the width or the separation closer together to make the surgery easier. And that requires weekly appointments where they're building a retainer for your baby that's stretching out the nose because the nose is shaped differently, moving the two segments or the two what we call alveolar ridges or bony lines closer together. So you go from trying to fix and close a pretty wide cleft to fixing or closing a very narrow cleft, which obviously is easier to do technically. And so in general, we're going to fix the lip. If it's on one side, meaning unilateral, around 3 to 4 months of age. If it's on both sides, meaning bilateral, I wait till they're 5, maybe 6 months of age, just because when you go from having tons of space to breathe through, right? So we said babies are obligate nasal breathers, and then all of a sudden you kind of squatch it all up and then sew it together. They can have a hard time breathing after that bilateral cleft lip repair. And, we don't want them stranded in the hospital for a long time, figuring out how to breathe and letting the swelling go down. And then for the cleft palate repair, in general, about a year of age, plus or minus, depending on their growth and development. Do they have underlying heart problems, et cetera, that take precedent over fixing their palate?
And since we're on the topic of cleft lip, can you go into the difference between complete and incomplete, how, surgery or expectations might be, if they're different, those types of nuances?
Right. So, and that's a great question. Incomplete, as you might imagine, means that the separation doesn't go from the top to the bottom of the nostril through the lip. So there is some attachment that is remaining. That attachment has been referred to eponymously as Simon Art's band. So if anybody has to take their boards and they're bored and want to get a test question right, that's one test question that shows up. And then you can have lots of different variants of that. It can be very subtle, called a microform, meaning very small cleft. And so there may just be a tiny notch or indentation in the lip, or it can be super wide, or it can be anywhere in between. And you can have a bilateral cleft lip, meaning both sides where one is complete and the other one's incomplete. I would say the other interesting part is that the bilateral cleft lip that's complete, this central part called the premaxilla can stick way out. And so that makes it really hard to fix it. And again, that's the embryologic frontonasal process, and it has these central and lateral incisors. And so you sometimes have to kind of push that back and pull it together. You can do some stepwise what's called a lip adhesion, where you sew the tissue together to kind of bring it back and then come back and do a revision surgery down the road. The goal in most of these surgeries is to recreate the muscular ring around your mouth. That's the muscle, the orbicularis oris. There are some types of repairs, particularly the bilateral ones, that don't incorporate the muscle all the way around. I personally think it's important to reconstitute that, just because you can pucker your lips, you can whistle. And if you don't get that muscle together all the way, then you can have what's called a whistler deformity. When you kind of whistle, then there's a little notch in your lip and it looks different. So I would also say at the time of cleft lip repair in general, we're otolaryngologists here. We love doing ear tubes. So we'll put ear tubes in these babies. And on average, they're going to need about 3 sets of ear tubes in their lifetime, just because, again, if they have a cleft palate, because the tensor veli palatini is not attached to the other side. And so there's a very high incidence of conductive and sensory neural hearing loss in these patients. So their hearing needs to be screened very closely.
And then on the topic of, that eustachian tube dysfunction, do you typically see that improve after surgery and after they grow? Or do some of these patients have lifelong issues with eustachian tube dysfunction?
The answer is yes. Actually, I wrote a paper on that, 15 years ago, and the average number of ear tubes that patients get will be about 3 sets of ear tubes. So about 50% of patients will resolve their eustachian tube dysfunction, or kind of the fluid behind their ears, after their palate repair, but 50% won't. So they need to be followed long-term by an otolaryngologist who understands what tympanic membrane retractions, cholesteatoma, screening for sensory neural hearing loss. A lot of these children will have syndromes, and so they have heart disease, they have cleft lip, they have cleft palate, they have breathing issues, they have trachs, and then all of a sudden, you're a year or two down the road, you're like, oh my gosh, this child has sensory neural hearing loss, needs hearing aids, has compounding speech delay, and so on. And so we as otolaryngologists need to be the advocate for these children getting proper hearing tests and getting to the bottom of that, just because you need to identify it by 1 month, confirm it by 3 months, and treat it by 6 months as an ENT. That is the mandate from our society. And so if we are not if we're not involved in the care of these patients, then I think that is a potential delay in care and could affect lots and lots of stuff.
So Steve, that's a great point that you bring up. I feel like for our babies that are born premature or have an extended NICU stay, I feel like, we do a pretty good job, obviously, with the newborn hearing screen, and then having them come back between that 6 to 10 month period for behavioral, for the risk of, delayed onset hearing loss. For the otherwise, isolated cleft palate baby who was a term baby past the newborn hearing screen, do you have like, hey, we're going to check your hearing behavioral regardless at before a year, 18 months? Because, on one hand, we're always thinking, well, how the speech develops will be a reflection of how they're hearing. But I would imagine with the cleft palate kids, because the speech is and articulation's affected, that can be hard. So how do you know, or how aggressive do you know to be sometimes with the hearing tests?
It's a great point. And I think that they should be screened every 6 months until you're pretty confident that they're hearing fine. And generally, that's probably going to be 2 or 3 years down the road. Just as you said, there's lots and lots of risk factors that these children end up having. And, there's lots of reasons why they may not be speaking. If we don't advocate strongly and work with the audiologist, I think that's, again, the partnership of working with the audiologist or the folks that test the hearing, working with the speech pathologist and saying, have we ruled this out? And it may require a general anesthetic to do a sedated hearing test to confirm that there's no hearing loss.
Right.
I would much rather spend a little time doing that than not have these conversations a year or two down the road, like, oh, your kid has a moderate hearing loss and now we're putting hearing aids on and now there's speech delay and you're already in all these thousands of other therapies and what have you.
Right.
Yeah. Just kind of thinking about, when they're first presenting, you mentioned the incidence of, also having other comorbid issues or having different syndromes. So are you referring all of these patients for genetic testing?
I personally am. I think that I love information. I think information is power. And there are some families that don't necessarily want that for themselves. And I think that that's concerns about social stigmata, concerns about what have you. I think I don't want to miss things. I'm not a geneticist. Lots and lots of these kids have genetic differences. Particularly if they have more than one physical finding, then there's a need for genetics. So you don't miss kidney disease, you don't miss cardiac disease, I think somebody just needs to see them, particularly if there's any type of family history, et cetera. And for the families, it helps them understand what their risk of having another child that has this same difference is. So absolutely.
And so talking about the Cleft team, can you go over exactly who, like if the patient comes to your Cleft clinic, who are the members there? Who are the clinical providers that they see there?
And I think it's different across the country. Certainly you want to have a surgeon, and the surgeon can be any number of folks with different backgrounds, otolaryngology, plastic surgery, oral surgery. You want to have a audiologist, a speech pathologist, geneticist, somebody that understands social work. You may need a psychologist, particularly for the children that have Apert, Cruzon, some of these rare, multifactorial conditions, just because there's a lot of hurdles that these families have to go through. And certainly as a team, you need obviously dentistry or oral surgery, orthodontics, all those folks. But again, if it may look different in different centers, but ideally, and obviously otolaryngologist, if the otolaryngologist is not the surgeon doing the cleft surgery, just there's lots of things that these patients need. And team care has reliable and reproducibly good results. So I think that's what families should strive for.
Yeah.
Obviously, the pandemic has really impacted people's access to care, and actually folks are doing cleft clinics remotely or virtually and other things. So there's some silver linings to get into the homes of families that have low resources and barriers to care.
Yeah, the more the merrier, for sure. I always feel better working with people who are experts in their area. Can you expand a little bit about, you mentioned social work. What types of, I think that might be one that I forget about, making sure patients are connected with social work. What types of services, or how do they help patients navigate through all of this?
Right. So if folks live 2, 3, 4, 5 hours away, you guys are in Texas. Texas is a very big state. And that I'm sure that there's literally lots of medical deserts out there where, some of these families are making the decisions. Do I drive 4 to 6 hours for a single appointment or for a day of worth of appointments, or do I feed my family? Who in my environment can help me with formula to feed my baby, to grow him or her big enough to have the surgeries and so on. So there are families that just don't have those resources, and the social workers can help plug them into the local folks that have access to that. Here in Georgia, we have a program called Babies Can't Wait, and that helps the hearing and speech, folks that are at risk for hearing loss or do have hearing loss in the first couple of years of life. So as physicians, as surgeons, from a kind of lean process standpoint, we don't need to be doing social work. That's not us working at the top of the scope. That's us being compassionate individuals. But I wasn't trained as a social worker, and certainly I can't execute on that. And so these families need to be supported in that way, and the physicians too, because it's not a good feeling for us to watch, this car accident unfolding on the highway. And you're like, I know that this patient has XYZ barriers to care, and therefore their care is going to turn out differently than the patient that's sitting in the next room. And that doesn't feel good.
I feel like I've had lots of different situations where I'm so thankful I have a social worker to help me, make my patient's care complete and guide me through these difficult humps and barriers. Because like you said, Steve, we're not trained to do it. We don't understand the mechanisms that are in place or how to utilize the resources that are there. And so I think families really appreciate when they have those other, social work available to them or other resources. Can you tell us a little bit about, like, when you do pre-op counseling for the initial cleft lip or palate? Again, I know the pre-op counseling for lip and palate, probably, especially when they're isolated, is pretty different, and it probably depends on the type. But how do you counsel families? What kind of expectations should they have? How long do they usually stay in the hospital? What kind of post-op complications do they, should they be aware of?
Right. So for the cleft lip repair, generally that takes about an hour and a half to do. Obviously, it depends on the width as far as how long and kind of what the scar will look like. If it's a wide cleft or separation and you're moving tissue around quite a bit, there will be more tension, and tension causes more scar. There is no scarless cleft lip surgery. The goal of the cleft lip surgery is to hide the scars and the lines that your other folks are kind of naturally looking for. So the philtrum are kind of the two lines under your lips. If you are recreating a scar that is in the same path or trajectory of that normally occurring line on other folks' face, that's the goal. right? And so really the goal of the cleft lip surgery is to recreate a scar in the similar line as the philtrum or the line on your lip and reshape the nose so that it's not flattened. Typically it's flattened. So recovery is a couple weeks. The kids are angry just because I put no nose on their arms, which keeps their arms straight and they're so they're not scratching at their face. Certainly that they can take those off when the family is with their child. And same thing with the cleft palate, they have to wear the no nose. As far as risk related to cleft palate, there's a 10% risk there'll be a hole or fistula. That again, the cleft is a separation, meaning that if you have a cleft palate, there's a continuous space between your oral cavity and your nasal cavity. That's why you can't create suction. And so you're going to close that off, moving tissues or mucosa from the sides to the middle and sewing it up in a very dirty place that undergoes constant physical trauma. And so certainly addressing some of the tension can reduce the incidence of fistula formation, but it still happens. And then they have food coming out of their nose and their speech is funny, and and so there's air that continues to come out of their nose. And so if a fistula does occur, revision surgery is necessary, and the efficacy or the success rate of those is only about 50 or 60%. So, and kind of that dovetails into my research, is that we're actually trying to develop strategies to reduce fistula formation and make it easier to heal.
I think that's a great segue into talking about research, because, we wanted to kind of ask you about your translational research and, how you stepped into that and how it's part of your career and, more about what that entails.
I like doing frustrating things that involve a lot of rejection, apparently. So basic and translational research is very interesting. I mean, we're all here talking on a Sunday morning because we want to make things better and we want to change things. And the translational research allows my scientific brain to bring the embryology, the developmental biology aspects to the technical surgeries that we perform and try to meet somewhere in the middle and say, okay, why am I getting fistulas? How do I control that better? And if you think about wounding and wound healing, folks are pushing all in on stem cells this and growth factor that for cutaneous wounds or burn wounds or what have you. There are not many people interested in oral cavity wound healing. And so as I've done in my whole life, I surround myself with people that are smarter than me that help answer these questions. And so
that's why I talk with Ashley every Sunday.
Exactly, right? It makes you feel smarter, and I working with a bunch of engineers at Georgia Tech, and they have lots of cool toys and growth factors and delivery vehicles, but they don't really know what the clinical application is. And so that's where I wanted to be a basic scientist and look at DNA and mouse models of genetics XYZ. And I didn't do very well at that because I wasn't doing it all the time. So really, what am I doing all the time? I'm doing surgery. I'm thinking about it. So how did I was like, okay, well, I got to pivot, right? That's the 2021 or 2020, word to pivot from this and, restructure that. But, I pivoted. I was like, okay, well, I'm not making success here. I love science. It's relaxing to me. And it's every time I get new data, it's like I'm unwrapping a Christmas present. And so, in leveraging the folks around me, we've identified something that can enhance wound healing in the oral cavity using an already FDA approved drug and reduce fistula formation in a mouse model. So, I think it's just saying, okay, what are the pain points that families have, right? So it's bone biology. We're trying to make more bone because really we haven't talked about filling the gap in the alveolus or the gum line. You have to do a hip graft from that. And if you've done one of those or you've seen one of those done, I mean, the kids are like limping around for a week. They have to stay in the hospital overnight. They may end up getting a hip fracture just to get some bone, right? And that doesn't sound very cool. So there needs to be a better regenerative strategy for that. So that's part of my lab. And then the other part is making oral mucosal wound healing. And again, I just care about kids because they're fun to take care of, but there is a bigger market size actually for the older people that you take care of that have, gunshot wounds or cancer surgeries or what have you. So that we need, as a society, we need to push hard to have better off the shelf strategies rather than doing a free flap, which is taking a piece of your leg and putting it in your mouth. That doesn't sound I mean, if you need it, you need it, but it doesn't sound great if you could avoid it or get something off the shelf. So it's really that curiosity and harnessing in on those pain points that you and I see in surgery and saying, why are we doing that? I mean, there has to be some, if I can have an iPhone that's the size of my palm that solves every problem I never knew I had, right? Why don't we have that same sophistication and have different therapies that, because we haven't moved the needle on any of that in a long time.
Right.
Absolutely.
So for somebody that's starting out, like, they're finishing their residency and they're within their first, 2 to 5 years of their career, what are the steps, or how do you actually get into translational research? How do you get your, internists and orthodontics and biomedical engineer? Like, how do you even go about making that research team develop?
Yeah, I think there's a couple components. Number one, you have to have a little bit of training or exposure directly, formally or informally, just so you understand kind of what is it you're doing, why are you doing it. You have to have mentorship. I mean, mentorship is so important, and some of my successes and failures have been tied to having good mentorship or not having good mentorship. So if you don't have good mentorship and you don't have somebody that's going to fight for you and that is going to knock down the walls that you're approaching, then you're not going to make it. So and that's fine. I mean, there's lots of good things to go. I mean, you guys have a podcast, right? You guys are crushing it there. So there's lots of ways that you can find your path. But if you really want to go into a field where you're going to spend months and months and months writing a grant that only has a 5 to 10% chance of getting funded, you have to love rejection and have good mentorship and have somebody patting you on the back, pushing you up the hill over and over and over. It's almost like Don Quixote, attacking windmills. Having said that, I mean, I wrote 18 R01 grants to get one.
Wow.
So yeah, so but I like it. It's curious. And so, not to be super wonky, but if you do a Berkman, which is a personality assessment, I finally realized that that's actually science, and like medical or just scientific curiosity actually is relaxing to me. And so that's why I think I gravitated to it. But if you do a self-assessment, whatever that is, and you find out that what you're set on doing actually stresses you out, you need to think about that, right?
That's great advice. I love that. And I love that you mentioned mentorship, because I think that's something, Gopi and I talk about that a lot. And it's so true that, like, when you start to talk to people who have been really successful, that recurring theme always comes up. Like, I surrounded myself with good people, with people who are smarter than I am, with, I kind of, climbed on the shoulders of other people to kind of push forward. So how do you, what's your advice for people who are like trying to find a mentor? Are you just really good at networking, or did you just happen to know, these people already, or how did those relationships happen?
And that's a great question. And the answer, is multifactorial, right? You see, again, it's all about knowing yourself. So if you're an introvert, right, you have to say, okay, I'm an introvert. This is super uncomfortable, but I'm not going to succeed if I'm not surrounded by good people in general. I mean, so you have to surround yourself with good people. If you're just starting out, before you take whatever your first job is, if you know that, you want to be the first otolaryngologist to ride on this, in the NASA next spacecraft, you need to find somebody that actually knows, that knows somebody. Because otherwise, if you go to the department and then you tell them, they're gonna be like, look, dude, I don't know what you're talking about. That sounds kind of crazy. And here's a whole bunch of patients for you to go see, right? So that has to be from the outset, you have to be very introspective, say, who am I? Can I do this? What are the things I need? Ultimately, from whatever residency program, fellowship program, faculty, wherever you are, you should have that conversation with your mentors there who know you, and assuming that you've been nice to them, that they want to see you succeed, right? So, again, if you've been somebody that's climbing on the shoulders of other people, but also stepping on their head on the way up, that's not the way to do it. But if there are people that are putting you on their shoulders, they're going to help you. They want you to succeed because that's their legacy. And just, again, the rejection part is real, and not everybody's going to want to help you. I mean, for me, I just reached out to somebody on LinkedIn the other day. They're not going to respond, and that's fine. So I think it's understanding and having that toughness. But again, it comes back to mentorship and saying, okay, well, I'm going to take this job at XYZ place, and this is what I really want to do. I'm very passionate about it. And them understanding it and asking them, like, who are my mentors going to be? How are you going to support me? How does this going to work? What's the balance of time, et cetera? And having all that understood on the front end. Because otherwise, if you get there and, they're planning for A and you're planning for B,
right,
somebody's going to see their way out. So,
right. Well, I'm sure.
Does that answer your question?
Oh, yeah. Yeah, no, I love that. That was great. Thank you.
So I was going to ask you, as the chief of pediatric ENT at Emory, how do you mentor your faculty? Like, how do you do it? Or is it just different for every faculty member? Is it usually on the mentee side? It's still a dance that's hard to know how to do well, if you will.
Oh, absolutely. I mean, I have made lots of changes to my approach. And I would say that business school was super helpful in that, because businesses actually understand that that's building the pipeline, right? I mean, in medicine, we're not ever taught about building the pipeline. It's like, are we allowed to curse on this?
Yeah.
Okay. It's like, look, goddammit, this is your job. I mean,
Right.
there was literally, like, when I started in my residency before the dawn of time, there was one attending that we worked with that, really you could measure your success and failure by the attaboy to goddammit ratio, right? And so, if you got more goddammits than attaboys, then that was a bad day and you just had to figure out how to do it differently. But, the business school really is about building a pipeline. And so at the beginning, I've been the division director for 6 years. I mean, I was trying to manage people and have them execute on the things I thought would make them happy. And that doesn't make people happy, because that ultimately ends up being micromanagey and whatever. And people hate that a lot. I can tell you from personal experience. So I have, again, pivoted away or had some self-reflection. And one of the big terms that comes up over and over in business and leadership is psychological safety. So you need to create that psychological safety for the folks in your environment to give you feedback when you are being pushy or being micromanagey, so that you can say, okay, well, that's not working. And because I hate being micromanaged so much, I sometimes will just let people do their own thing. What I say to them is like, look, what I brought you here to do is to take very good care of patients. And if you're doing that, that's all I need you to do. If you want to get promoted, that's very different. Here's what that looks like. Here are the things that you can do. In some ways it's choose your own adventure kind of story, and helping frame things. And even onboarding has turned and become a lot different. Not that I don't want to be micromanaging, but there's so many things that people don't talk to you about. Like, it's super stressful to start your first job and you have your first complication, and and again, the right word is not second victim, because I think people don't like that. But if you have some real life stuff that goes on and you're operating on people, and ultimately that's going to happen, that's very injurious to you. And if I haven't prepared you for that, right, then that's hard. It's hard for you. It's hard for me. It hurts everybody. So there's a lot of things I've done differently. But, I think I try, I like giving people things to do. I'm fascinated by a lot of things, as you can tell, and certainly like to delegate and grow people's careers. But then there are people that say, hey, look, dude, I'm full. I'm good. No mas,
Right.
And again, if you create that psychological safety where, like, okay, you're not looking at me saying, am I getting an attaboy or God damn it? But like, hey, this is a conversation. Our division has 6 female surgeons and 2 male surgeons. And again, the lives that my 6 female surgeon partners walk is very different, and so I try to hook them up with other mentors that have walked that same space, just because there's different things going on. So I don't know if that was too rambling, but that's it's been an evolution, is the short way to answer that question.
Yeah, I think that's great. I think when I think about like really highly functioning, successful organizations and groups, I feel like it's kind of like an orchestra where everyone is like living their best life and like really, living out what they're passionate about, which is different for everyone. So, you have some people over here who just, read, the white journal all this, in their free time.
Right.
And you have other people that are, wanting to do other things. And I think I love that approach of like, make your own adventure. Let me give you some general guidance on kind of, what it looks, what promotion looks like or different things like that. But
Right.
it can look different for everybody. We're not trying to make, all these clones of like, this is this is what success
we don't need
looks
everybody
like.
in the department to be the chairman or chairwoman.
Exactly.
Right?
Exactly.
I have to say it's got to be hard. Maybe my thought is maybe that's just me, but as we are in medicine, there are certain things or boxes that you have to check to get into medical school. There's certain things that you have to do to get into residency, to a fellowship. And so the choose your own adventure mindset, I think, can sometimes be a little late for some of us in medicine. And I feel like it's important to start having that mindset earlier on and really encouraging our residents and our medical students, because it's so easy with the way we get into things, right? It's a match. You're not choosing as much, that power isn't there. And yet there's so much in terms of self-awareness and self-empowerment just from getting comfortable in your skin and being okay to pivot and understanding what you like and don't like, and knowing when you can say no so you can say yes to other things. And it's definitely a process that continues to evolve. And it's something that I do think it's important for us to continue to encourage in our trainees and our colleagues.
Absolutely. And I will say one other thing. I mean, when I hire folks, I'm hiring them for a pretty specific thing. So I have that conversation on the front end so that their expectations are like, hey, we already have 2 people that do XYZ surgery. We don't need a third person. So if you're coming here for that reason, that's not what we need, and so that some of those basic fundamental expectations are being met. And then from there, it's what growth do they want and how do they balance their lives? And I would say that leveraging the university or the practice or wherever you're in to get the most out of that, as surgeons, a lot of us put our heads down and just grind, or at least that's the way it used to be. I don't know that that's happening as much anymore, which I think probably is okay. But, picking your head up and saying, okay, what are people trying to help me do? And for example, Emory has a lot of dedicated time for, the younger folks to have career development, to have, how do you be a teacher, right? So you walk out of residency or fellowship, nobody's ever sat down and said, okay, here's how to be a good teacher. Here's, like patient feedback, getting a nasty gram because somebody hates you because you saw them and you made them angry, or you told them something they didn't want to hear, or it wasn't a good day. You're used to getting hundreds in all your tests, and then somebody gives you an F.
Yeah.
It's hard. Not to, despite the fact that there's 100 people that walked out of the office that day that loved you, if that one person, that doesn't like you, which happens, it's hard.
It's true. Those words hurt. They hurt deep.
Yeah. I never want to see Dr. Goudy again. You're like, okay, I get it. I'm sorry.
Ouch. Yeah. Well, can't let you leave us today without talking about Dr. Knows Best, your startup and your device company. Can you tell us a little bit about how you started that and what that is and what it does?
Yeah. So, and it kind of dovetails into what we were discussing earlier. So babies are obligate nose breathers. So when they get a bad cold, and I have 3 kids, they can't breathe, they can't eat, they cry all night, you don't sleep. It's a super tense, uncomfortable moment. Usually Saturday night around midnight is when it starts, when my kids have been in daycare. And, even as an ENT, I'm like looking at, okay, you've got the blue bulb, that doesn't work. It occupies your whole hand. So you're trying to get in there and they're clawing at you and they're like, okay, that doesn't work. The mouth suction device where you put one end in your mouth and you put one end in their nose, that I'd never used that, but that's not hygienic. And there's, again, you're still having to fight and chase your kid around because you physically can't hold their face, hold their arms, hold their legs. And so my wife had told me, said, hey, you need to come up with something better because this is not good. And so over time, again, the curiosity and finding those pain points and listening to your families. I mean, I have a distinct memory of going into a family's room probably 5 years ago, and they're hospitalized, as a baby has Down syndrome. We all know that those babies have smaller noses, they get a cold, they can't breathe. And mom's like, look, I'm just stuck here because I just need this wall suction. And she had bought a very expensive nasal suction device. It's basically a small vacuum cleaner. It just has a vacuum cleaner fan in it. And she didn't have a lot of disposable income just because she felt paralyzed by her current situation. So, we created a nasal suction device that fits on your index and your middle finger so that you can use your thumb and your pinky finger to hold the baby's head. And then with your other arm, you can actually hold the arms and really get it done and be very efficient. And using a pump that provides hospital grade suction. So, it's rechargeable, portable. If I'm willing to pay $1,000 for this little, electronic thing, I sure as heck want something that's going to be efficient, lets my baby breathe and eat, and then I can sleep. I mean, you think about what a good night's sleep is worth. It's worth a lot. So, and so Dr. Knows Best is going to be a company that focuses on these pain points. I read an article a couple of weeks ago that really called it silent suffering, right? It's like, okay, why are you suffering in silence? Why are we using these things that are not sophisticated, right, to take care of the thing that we were willing to die for, right? I mean, we're willing to pay anything, do anything, and we're kind of bringing a knife to a gunfight, if you will. And so, we as a company are going to focus on health and wellness products for babies and young toddlers and so on. So that these silent suffering moments of, I assume that you guys both have kids, but there's a lot of things that you do that nobody told you was going to be part of being a parent. I'm not going to address blowouts and all this other stuff, but there's other things that we're using that, you're half sleep crazed and sleep deprived that you don't really even realize that the things you're using just seem stupid or not helpful, or you wasted the money or, Yeah. So we're going to make products that address those pain points that people, and again, really the goal is to educate them, right? I mean, if you Google cold, you're going to get a bunch of information, but who should be telling you about management of colds? It should be us, right. Otolaryngologists. We're kind of stay in the nose, right? Our hashtag is not a problem. So addressing that, addressing those kinds of things, I think number one is fun and we could make a business out of it, but really educating families on what evidence-based practice looks like and how, and identifying additional pain points that we can make better is the goal of our company.
So is it available, Steve? Like, are families able to purchase, or where can they find it? Right. Or what's the timeline for that?
Yeah, so we launched about 6 weeks ago. So we are available direct to consumer on our website, drknowsbest.com, DRNOZEBEST, Dr. Knows. There's kind of a play on the word nose. And we're also on Amazon. And so you can find it in both places. And we're working on product number 2 that will come out in late 2021 or early 2022. So really, we've had great feedback. The folks that are not enjoying the other kind of cave person solutions to nasal cleaning, they're like, look, this is great. It's efficient. It gets the job done. Literally, there are people that have told me that to suck out their baby's nose, they physically sit on their child, pin their arms down with their knees and the head between their knees to do it. And that's crazy. Yeah, exactly. It's not, nobody, no. I'm a
pediatric ENT and I've done it many times.
Right. Right. And so we want to restore that mom, or dad and baby relationship because that's next level, nasal suctioning. So.
Yeah. I love that. I mean, we're developing a commercial space flight, so I think we should be able to get in there. We should be able to take care of a snotty nose with a better system.
Right. Well, I think I would also point out that if part of the system you're using where you're inhaling viral particles into your distal alveoli, that does not make a lot of sense to me. I mean, certainly you may get a cold, but that's like having somebody sneeze in your mouth or down your throat, and it just doesn't, there's not an N95 in any of those devices,
Awesome. Well, congratulations, Steve. That's so exciting. I'm super excited to check it out for myself as well. Any other final pearls or thoughts that you want to leave on whether it's a Cleft care, research, leadership, a startup, life for our listeners?
I think be curious and find good mentorship. I mean, that's the most important thing. All the other stuff, I think you just choose your own journey, but really make sure you have the mentorship, and somebody that supports your curiosity, and just be honest with yourself. I mean, if you haven't like looked in the mirror and done, we as human beings, we're introspective, but if you're a physician and you've taken lots of tests, do a test on yourself. See where you are. What are your gaps? Do you want to close them? How painful is that? I mean, honestly, when I started doing that and really through business school, kind of looking at myself, my personality, and my like normative behaviors, my stress responses, I became a better husband. I became a better dad. It's like, why am I being a jerk? I'm stressed out. Okay. And then it has all these unintended consequences. And, if I could go back and do it again, I would have started down that journey, 20 years ago rather than 5 years ago.
Very cool. I love it. Well, Steve, if our listeners want to connect with you, online, are you on social media?
Yeah, I think LinkedIn is great. I think, check out our Instagram page. We have Facebook, through Doctor Knows Best, either one, or you can find me on the Emory website, whatever, depends on, what they're coming for and what they want advice about. But, I'm happy to at least tell you what not to do because I've learned a lot of that. But yeah, I think, if you want to learn more about boogers or you want to talk about the Doctor Knows Best, then kind of come to us through the website. If you're more interested in translational research and writing and getting rejected over and over and over again, then, my lab has I can give you a link to put in the notes for the lab website. So
awesome.
Yeah.
Awesome. Well, thank you so much, Steve. It was really nice to connect with you today. We appreciate your time. For our listeners, thank you for tuning in. Continue to subscribe, hit like, send us feedback. If you want a different topic, speaker, come on the show.
For sure. Subscribe, rate, and share. It helps us grow. It supports our efforts to bring you this content. Follow us on social media. We're on Instagram, we're on Twitter @_BackTable ENT. Thanks for stopping by the show.
Sharing is caring, y'all.
That's
sharing
right.
Is caring.
You knows it.
There it is.
Nice.
Awesome.
That's a wrap.
Yeah.
Yeah.